Welcome to Challenging Silence, a podcast from Women's Health and Women's Hands Community Health Center.
On this show, we are having much needed discussions about topics related to female genital mutilation or cutting with survivors, advocates, and community members. We're your hosts, Tomilola
and Nanti. Challenging Silence is brought to you by the Flourish Project, made possible through funding from Women and Gender Equality Canada.
You can listen to this podcast series on all major podcast listening platforms and our website, flourishaccess.ca.
Please note that this podcast covers topics of a sensitive nature, including domestic abuse and violence. To ensure privacy and safety, some guests have chosen to remain anonymous.
This podcast is age appropriate for 16 plus.
Some have argued that FGMC is not practiced in Canada, so it's not a big issue for Canadians. Though the government has acknowledged that it is a human rights violation that should not be tolerated and provides resources to NGOs in African countries working to eliminate the practice, not much focus is on the thousands of survivors and many girls at risk who call Canada their home.
Today, we are talking about FGMC in a Canadian context. Get ready to hear some words of wisdom from Dr. Bilquis Vizanchi. She is a professor at the University of Montreal's Faculty of Nursing and a researcher at the Public Health Research Institute of the University of Montreal. Her primary research interest is in the challenges of providing quality care in a multi-ethnic setting from a perspective that considers gender, ethnicity, immigration experiences, and equity. Currently, Bilquis is the lead of the RHC for FGC project, which is one of 13 GenderNet Plus consortia funded by the Canadian Institute of Health Research and the European Commission. A very warm welcome to you, Bilquis, and you can tell our listeners a little bit about yourself.
Thank you very much for this introduction. Good morning, good afternoon, good evening. Depending on what time of the day our listeners are taking up into our conversation. So I'm pleased to be here today and really appreciate the invitation. So as you said, I'm based in Montreal at the University of Montreal as a professor and also a long-time partner in research in understanding what are the determinants that help or affect healthcare seeking for women, especially those who are new arrivees in Canada, so that as a healthcare professional myself, trained as a nurse and training upcoming nursing students, as well as a number of those who are in medicine and other healthcare professions, such as social workers, the understanding of those determinants that would affect not only access, but also adequate use and receiving quality of care of those who are new arrivees in Canada. So I guess that would sort of, in a nutshell, sum up my work as a researcher and as a professor at the University of Montreal at the School of Nursing and Public Health.
Thank you and welcome again, Bilquis. So I'll start by saying that you do some amazing work through GenderNet Plus. Tell us about the RHC for FGC project and why initiatives such as yours and the Flourish project are much needed here in Canada.
Thank you for the question, Tomilola. Indeed, so this project is an initiative that is including not only Canadian-based partners across Canada from Nova Scotia, Quebec, Ontario, Manitoba, and very newly added from Alberta. And of course, we have a number of partners from British Columbia. In addition to these regions and provinces in Canada, we also have a diversity of expertise from those women and a few men who work in the area of understanding what are the challenges for women and families who arrive in Canada and have experienced FGMC in their country of birth or country of origin. So it is to look at a better way to welcome these women, girls, families, so that in the perspective of healthcare professionals, so a diversity of healthcare professionals, we can be better prepared to offer a large array of services. So in terms of diversity of expertise, we have women and men in the medical field. And I believe, Familola, that you have been carrying out some discussion with some of our colleagues who are involved in RHC for FGC, which means respectful healthcare for women and girls living with FGC. And it has the added element of GenderNet Plus because it's funded by the European Commission and local Canadian health research organization, as well as other funding organizations in Europe. So in terms of Europe, we have partners, similar diversity of expertise in France, in Belgium, in Switzerland, in Sweden, and in Spain. In addition to this expertise, I'd like to add that in Canada, we have this added value of the contribution of civil society organizations, such as Women's Health in Women's Hands, and a number of organizations in Quebec, such as Afrique au Féminin, the RAFIC, which is a network to support women who are from various countries in Africa to learn better about how to live in Canada.
Thank you so much for telling our listeners more about your work and the good work that your project is doing. Pan-Canadian and international collaboration and expertise is really needed in the quest to provide better and comprehensive support to FGMC survivors and other women impacted by the practice who call Canada their home.
And for our next question, there are over 100,000 people in Canadian immigrant communities who come from countries that have documented practices of FGMC. But we do not know the prevalence of women and girls who may have undergone or may be at risk of undergoing FGMC. Some other immigrant receiving countries, such as Belgium, conduct periodic estimates of the prevalence. Do you think this activity should be implemented in Canada? And what are the possible benefits of collecting this data?
So thanks for this question, Nati. It's an excellent remark you just made about whether there are benefits in calculating estimates of prevalence in Canada. And I insist on the word estimates because it is difficult to directly calculate prevalence. To do so, we would need to have a direct clinical exam, I would say, and confirmation by those clinical experts who would know what they're doing by indicating that, yes, indeed, with my clinical exam, this woman or this girl has undergone FGMC. And moreover, we would be able to abide by the typology offered by WHO, the World Health Organization. And we don't really have, first of all, that capacity. And most of all, but it would be not necessarily ethical to round up, quote unquote, women to then assess clinically if they were. The other way that potentially could be done, which is done in countries where was documented that the practice is happening more frequently, then there would be self-reports by women. So then we would ask women, do you have any recollection that you have been exposed or do you have undergone that practice? Otherwise, other way to do it, which has been done frequently in some countries in Europe, namely Belgium, is called indirect estimates. And indirect estimates are to basically look at the census data of the specific country. So in Canada, we recently have released census data of 2021. So we do have the most recent data within which we have in the census the country of birth of those who have responded to that census. And then we would take that percentage and do an estimate projection or prevalence calculation with the country of origin estimates of prevalence provided by international organizations such as UNICEF. So that's how it's being done. So once we do that, you can understand that those are estimates. And we can do it by province, or we can do it by smaller areas within the province, in a city. But then we would tend to have data about where families would be residing, and it would be a bit difficult to go to that level of detail, given that we do not want to create any additional stigma about the fact that in a specific area there is a high number of families coming from country X. As long as we have enough of a sense at a larger scale where women, girls, and families are, one of the main reasons why we would want to do, and that's the response to your question, it's because we want to provide the best care possible to those who have these complex needs and that we are not aware of the existence of it. When I talk to some colleagues at the management level, and especially trying to bring in the argument that we need to provide resources, strengthen resource partners in the community who have expertise, not only in research, but in providing services, but we need to continue to make them sustainable and strengthen them. A lot of managers would tell me, really, Bilkis? It happens in Canada? People sort of want to know the numbers. They want to know, well, if there's enough, fine. But it is difficult to explain to people, at times that only one person with complex needs is enough, that we need to provide to that one person the best possible care. And in order to provide that best possible care, we need to train. We need to adequately train. We need to respectfully demonstrate the complex needs and how to provide the diversity of potential care that we can give to the ones who sometimes do not feel comfortable, at times too traumatized to undergo another type of trauma in asking the question. So basically, that would be a long answer to your excellent question.
Thank you so much. You really did say a lot, and I'm sure our listeners will be appreciative of so much of the information that you gave us. And, you gave us a lot to think about and a lot to digest. What I did take from it is you mentioned the difficulty, but not the complete impossibility of capturing these estimates. And I think that's very important. And this is where collaborative efforts come in. And we talk about the key stakeholders, including the government of Canada and organizations such as Women's Health and the different other organizations that are really dedicated to this work. You also mentioned observing from the international aspect the strategies and also trying to implement them according to the Canadian palette, or rather the healthcare systems of Canada, to make it work. And I think lastly, you had stated the importance of providing excellent care requires a level of responsibility, not only for understanding, but in order to implement holistic and effective care for whoever needs it. And I think that's very important. So thank you so much for answering that question.
Thank you for that, Bilkis. We can all agree that estimates of prevalence, although difficult to collect, will definitely put a number to the need of impacted women. And having these numbers would raise awareness for service providers to do much better and become more knowledgeable about how they can support survivors appropriately in a culturally sensitive and trauma-informed way, which is much needed here in Canada. Once we do seek to document these estimates of prevalence, we now become accountable to ensure that the women and girls impacted by FGMC, they get the support that they need. What are the resources currently available in Canada to support, reach out to, and inform these women? And what are the resources that need to be available? So the ones that maybe we've seen are widely available in the UK, in Belgium, and Canada needs to adopt that.
Thank you so much, Tomila, for the question. And in fact, I find it very interesting, our conversation, and I'm very appreciative of it, because the best way to provide support is to, first of all, raise awareness that they exist, those services. And we do have like an amazing diversity of rich resources that exist in Canada, but unfortunately, it's not well known yet. And in fact, you have been very instrumental at Women's Health in Women's Hands and at the Flourish Project to actively gather those resources so that it's available on your website. There's a rich diversity of what exists across Canada, but also internationally. And the international resources are interesting. But the example, for instance, of a woman who has undergone type 3 FGMC, which requires to some extent defibrillation, that woman may not know when to do it, where to do it, and how would she be accompanied so that she's adequately prepared and then she's adequately informed. So our colleagues within our RHC for FGC GenderNet project have developed this unique video to explain to women. And that video done by the Belgian partners is very interesting, short, in 9 languages, but it does not reflect access to healthcare services to Canada. So a Canadian woman who would be watching that video would be informed, but then would not know where to go to actually receive counsel in the steps to take in Canada. So I'm glad that you're asking this question, because resources can be developed. In order to be used, they need to be known. And once they're known, they need to be, accessed and used. And that's the only time we can say that resources were actually reached out to those who need them at the right time. So I'm glad that in partnership with Women's Health in Women's Hands and a few of the community organizations across Canada, and I believe that Mosaic in Vancouver has been doing a lot of work for those who are newly arrivees, and the partnership that we have throughout our project will help to build capacity without repeating the same work. We also have End FGM Canada that does a lot of work building on the lessons learned from End FGM Europe.
Thank you, Bilkis. You've definitely highlighted the resources that are needed for adequate support, and resources that other immigrant receiving countries already have available. We definitely have more work here to be done. And as you said, as we've all said earlier, collaboration. It's important. We need to collaborate and do the same work that our partners are already doing abroad. In terms of resources here in Canada, it's definitely been difficult to find FGMC specific resources. There are just not enough of them here in Canada. From the researcher building the interactive map on the Flourish website, I do know that we have other organizations who provide an array of support to women who have experienced gender-based violence in general, which would be helpful for FGMC survivors. Thank you again for highlighting all that is needed here in Canada.
Thank you so much for that, Bilkis. And as a closing question, what do you hope to see in the future of FGMC work in the Canadian context?
Thank you. Thank you, Nanti. So I guess I'll build on my response just earlier in terms of, how best we can do to collaborate and make sure that resources that we will gather and provide awareness will be known by women and girls. I think that's what it is. I think our partnership currently is growing, is building. We have a large array of resources slowly being built. They need to be more accessible to women. They need to be known to women and girls and their families. We also need to continue training schools, colleges, universities. They have new videos and video capsules that are happening How do we transform these tools so that it's not just a sort of an event that you encounter and say, oh my God, this woman, what's happening to her? But rather it becomes an adequately integrated learning and competencies that one would learn as they become healthcare professionals in Canada, as specific needs, as complex needs, and not that it happens all of a sudden when you are in a clinic. And to do so, that training would require also open capacity from universities, from colleges, from schools to include community-based partners. That would be really my hope, is that we work together in devising those training modules and making them accessible, assessing them, reviewing them together, and then especially, I guess, making sure that women who need them can access them. And Canada is a big country. Canada is a bilingual country, so we have that additional challenge. Resources exist much more in English, fewer of them in French. We have capacity in French. What needs to be translated? There are women who come from some of the countries where the practice happens who do not yet speak adequately English and French. I would hope that we could have and we could secure a sustained funding for translation in the local language, at least to inform, so that can build capacity in terms of the local language, but also then in English and in French. So a lot to do, but I think we do have the capacity to carry out that work in partnership.
Thank you again. A lot of practical examples that you gave today. And I'm sure as we continue to have these discussions and as we continue to work collaboratively, some of these will come to fruition. Thank you again, Bilkis, for joining us today.
It was a real pleasure. Thank you for having me.
Yes, thank you again for joining us today. As the world continues towards the United Nations global promise of ending female genital mutilation by 2030, Canada has to do more to make positive changes towards this goal. Positive changes towards abandoning the practice, and most importantly, positive changes towards supporting its survivors and protecting the many girls who might be at risk. Next week, we will dive deeper into the real work of supporting and caring for survivors of FGMC.